Doctors with Africa, QAM. Another option, the Medical Concierge Group and eHealth Partner. As an introduction to this 2I project, I need to mention that Lamu sub-region was achieving the TB case finding target. However, the TB cure rate and treatment success rate had stagnated at 65% and 72% respectively in the year 2018-2019, and this was against the national target of 85% and the global target of 90%. So strategies to improve treatment outcomes were necessary to prevent the drug-resistant strains that would erupt due to people failing to either get cured or complete their treatment, and also to interrupt the transmission of TB and avert some of the deaths that were being reported during this time. So timely interventions were necessary given the fact that treatment outcomes are reported a year after. TB treatment outcomes are reported a year after. So if timely interventions were not made or are not made, it would be extremely difficult for us to get better outcomes in the subsequent quarters. So what methods did we employ to see to it that we see an improvement in the treatment success rate and cure rate? At the close of the April-June quarter 2019, we engaged the district and site level teams in the supported 70 facilities, the diagnostic and treatment units, and we looked at the gaps that were existing, which were majorly in synchronizing appointment systems for the TB patients that were being managed. We also trained community workers like the village health teams and community linkages facilitators who were attached to the clinics. The healthcare providers were also empowered to review and monitor registered clients on a monthly basis. And as they were doing this, they were working in conjunction with the community workers to ensure that at least monitoring patients on treatment who were bacteriologically confirmed at 2 months, beginning of 5 months and 6 months is done. So what were the results that we got as a result of these interventions that were made? The cure rate and treatment success rate improved, and we see a cure rate of 80% in April-June 2020 and a treatment success rate of 85%, and this was against the baseline in July-September 2019 of 65% and 72% for cure rate and treatment success rate. The graph shown here indicates the trends in TSR and also in cure rate. So as we observe, you see in July-September, this is our baseline, which was 72%, the dark blue line, 72% TSR, but it kept on increasing 75, 84 to 85 in April-June. And then also the cure rate, the light blue line, shows the trends in the improvement in the cure rate. October-December, it still remained the same at 65%, but this was majorly attributed to the documentation challenges that were being seen for patients whose sputum samples had been picked and not updated in the register. So at the time of reporting, this hadn't been done, but it was addressed, and we see the trends improving and they're increasing to 76% in Jan-March, and then eventually 80% in April-June 2020. As I conclude, we note that active cohort monitoring improves TB treatment success rate and cure rate. This is because the frontline health workers, the TB focal persons, and also the community actors, the VHTs and CLFs, are able to make timely interventions as on a monthly basis as these patients are managed. In situations where a patient has missed an appointment, this patient is followed up immediately to establish factors that could have affected their return to receive their medications. But also, some of the patients who could have fallen ill are also identified, and interventions are made to ensure that they are managed well to avert any eventualities that may come along. And then also for cure rate, with the timely monitoring of sputum for bacteriologically confirmed patients at 2 months, beginning of 5 months and 6 months, the results that are picked, or the samples that are picked and analyzed, results are logged into the registers, and this in a way enables the teams to assign the treatment outcome for that specific patient, which wasn't the case. And we also see that engaging the community structures, if the community structures are strengthened, they will definitely complement on the monitoring that is being done, because still, as I've noted on the real first point of active cohort monitoring, you see that the communities, the players in the communities play a significant role in ensuring that patients are retained and patients are monitored on a timely basis. I wish to appreciate the National TB and Leprosy Program and the Ministry of Health for the guidance, the support that they have provided to the team. I also want to appreciate the district leadership, DHOs, DTLSs, TB focal persons, and then partners, CSOs that we work with, the village health teams, and the community linkages facilitators. I thank you for the opportunity you've availed to me to showcase what we're able to do in our region. Thank you very much.
Hello. The use of intensified case finding stamps to improve TB screening and case notification in 2 selected pilot facilities in southern Karamoja. An innovation by the Regional TB Office and Doctors with Africa, QUAM, presented by Probe Fontiano, the Regional TB and Leprosy Supervisor, Karamoja Region, during the 7th National Quality Improvement Conference in Uganda. Introduction. In 2014-2015, National TB and Leprosy Control Program Uganda carried out a nationwide community-based TB disease prevalence survey. It was reported that among symptomatic presumptive TB cases who sought care, only 16% were offered a TB test. That is to say, 10.3% sputum examinations and 6% chest X-rays were done. In addition, the survey identified TB cases among individuals without TB symptoms, bringing into question the sensitivity of the current symptom screening. 2 factors were isolated: low screening for TB among patients seeking care at health facilities, and low index of suspicion for TB among patients having signs and symptoms of TB. All these led to low TB case detection, notification, and misdiagnosis at health facility level. Method used. Dr. South Africa, together with the regional TB office, piloted the use of intensified case finding stamp in 2 high-volume facilities, St. Pius Depot Health Center 3 in Moroto District and Matany Hospital in Napak District, all private, not-for-profit health facilities governed by a Catholic Church. Before using the stamp, the health workers were oriented on purpose of the stamp, how to use it, and what it meant to achieve. Patients' medical forms were stamped to guide the health worker during screening or triage. This was done for all patients seeking care at all the service delivery points. The clinician or health worker attending looks at the findings marked on the ICF stamp from the patient's form or booklet, and is therefore reminded to evaluate individual patients who are presumed to have tuberculosis and sends them for TB investigation or manages them appropriately using the TB diagnostic algorithms. Results. In St. Pius Depot, a facility with a catchment population of 16,422 and expected to notify 21 TB cases per quarter, the presumptive cases identified ranged from 41% in January-March to 134 presumptive cases by October-December 2019. The cases notified increased from 10 in January-March 2019 to 37 by October-December 2019. And the notification rate equally increased from 48% to 176% by October-December 2019. In Matany Hospital, a facility with a catchment population of 161,698 and expected to notify 203 TB cases every quarter, the presumptive rates increased from 69% to 110% by October-December 2019. So generally, there was an improvement in total numbers of TB cases notified in the pilot sites, as noted by the statistics. Looking at individual health facilities, you can realize the trend of St. Pius Depot from 48% started increasing by July-September 2019. They were able to notify 100%, only 21 cases expected, and by October-December they were able to notify beyond 100%. In Matany Hospital, the case notification also increased from 69% to 110%. Resumption of symptomatic TB cases seeking care improved in 2 pilot facilities with the introduction of the identified case finding stamp. For example, the number of presumptive cases improved from 41 cases in January-March to 134 cases by October-December 2020. The ICF stamp provided an avenue for reminding clinicians or any health worker attending to our patients to evaluate patients for tuberculosis. The case notification rate in these facilities increased as demonstrated by the trend, the graphs. Lessons learned. The use of intensified case finding stamp for screening at all entry points improves TB case notification. The ICF stamp provides a summary of symptoms to look out for when screening for tuberculosis. It made it easy for the health workers to remember to screen and presume patients for tuberculosis. In conclusion, health workers often miss how TB cases and focus on other disease conditions. So, the ICF stamp provides a simple tool in trying to solve this problem. The ICF stamp is very simple. It's a cost-effective innovation that can help us along the continuum of care to continue improving the services delivery. The innovations always must be specific to a need. Doctors with Africa QAM scaled up the use of this stamp in health facilities across the 5 districts in southern Karamoja. And with the support from other implementing partners in the region, this innovation has been scaled up to cover the other 4 districts in the northern Karamoja. These have had great impact on TB screening, presumption, and notification in the entire region. Recommendations. The use of the ICF stamps as a screening tool for TB in all facilities. Operational review. Study, monitoring, and support supervision on its effective use and implementation in the TB case finding is very crucial. I acknowledge Uganda Ministry of Health, National TB and Leprosy Control Program, the Regional TB and Leprosy Office, the DSOs and the DTLSs of various districts in the region, and other TB implementing partners in the region. Thank you.
Hello everyone, this is Ronald Mwesigwa, working with USAID's Rights EC project as a Cluster TB officer, and I'm presenting a case study from Namutumba Health Center 3 in the Namutumba district, which was aimed at improving PPT initiation among children and adolescents 0 to 19 years during the COVID-19 pandemic. And just a brief introduction. In 2013, the Uganda National Guideline on Collaborative TB Activities recommended the use of isoniazid as one of the strategies to control tuberculosis disease among people living with HIV. It was estimated that 50% of new adult cases of tuberculosis in Uganda are co-infected with HIV, and children under 15 years accounting for approximately 6% of all the global TB cases. So in July 2019, Dr. Luther Cheng, the Minister of Health, launched a 100-day accelerated scale-up plan for TPT, targeting over 300,000 people living with HIV in Uganda. However, by March 2030, Namutumba Health Center 3 had only initiated 28.4% of the 109 children and adolescents who are eligible for INH in that period of performance. So this was associated to complete documentation, TPT, stock out, knowledge gaps among the health workers and the caregivers, then overrepresentation of adolescents and children by their caregivers, and this was more worsened by the COVID-19 pandemic. So after identifying the gap, we came up, we did the root cause analysis, and we came up with the several challenges, of which we divided them into two, between the provider initiated, which means the issues within the health facility, then the client initiated, which means that the issues coming from the clients themselves. So among the provider initiated related issues, we had a knowledge gap, multi-month drug refills, INH stockouts, and poor documentation in the INH register. So this was addressed individually. For the knowledge gap, we held mentorships and coaching at the facility site. For documentation, we assigned an individual to take us through and to be responsible for documenting all INH information into the register, make sure that it's up to date. The multi-drug, multi-month refills, we followed up and delivered INH for those clients that had received multi-month drug refills, and the poor INH, the stock out of INH was a national issue. So after the districts had received their INH, we redistributed according to the demand of the facility. We continue with the client-related issues, and knowledge gap and lockdown were some of the issues that we contributed from the side of the clients. So knowledge gap was addressed by holding caregivers meetings, where we addressed the caregivers about the importance of INH and its advantages to their children and adolescents. Then the lockdown came with several issues, transport constraints, since most of the readily available transport was use of motorcycles, the border borders, and by then border borders had been halted, and even when they were released, they would only recommend one person per border as a passenger, so the caregivers couldn't move with their children and adolescents to access health services and health facilities. This was also addressed through follow-up and conducting community INH delivery to the children and adolescents within their communities. These are some of the pictures showing what we did. This is a mentorship or an on-site coaching. It was held as a CME. We addressed the challenge that we had to the health workers. We came up with strategies and how we are going to implement them through some of these meetings and CMEs. And then we see a file auditing and line listing. The community arm and the facility team went through the files to identify the children and the adolescents that have never been initiated on INH. They tagged them, and we made a line list for all of those that were eligible for INH for easy follow-up. So during the caregivers meeting, like I said before, we were in a groups of 10 while observing the Ministry of Health COVID guidelines. We shared information of the importance of INH and the planned visit to visit their homes as we deliver INH to their children and adolescents. As I said before, we assigned a focal person to ensure timely documentation, the INH register, followed up, assessed eligibility, and issued TPT alongside art for those who had missed in the community. So this was done by both the facility and the community team. These are some of the pictures showing. This is a community caregivers meeting at the facility, and this is showing our health worker with the community volunteer delivering INH at the community level. So what did we achieve after that? So by September 2020, a total of 99 out of 109 eligible children and adolescents had been initiated on INH, which translated to a 90.8% achievement. So on the graph, we see in quarter 4 of financial 2019, actually this is the period when the 100 days we accelerated. We see that still, even during the acceleration, only 31 out of the eligible children and adolescents within that period were initiated on INH. This went constant through quarter 1 of financial 2020 until financial 2020 quarter 2, when we identified the gap, addressed it, the gap to the facility teams. We came up with strategies to implement to see that we improve on our INH initiation, and which include capacity building, file audits, timely documentation, and delivery of INH to the community. And after starting our implementation in quarter 2 of financial 2020, we initiated a total of 31 children and adolescents on INH, which made it to a cumulative number of 62 clients initiated on INH. And between quarter 3 of financial 2020, we initiated a total of 37 children and adolescents to make it 99 out of the 109 eligible children and adolescents. So this translated to a percentage of 90.8. So it showed us that our strategies that we implemented in this period from January to March had a very significant effect on the improvement of INH among the children and adolescents to enable us improve from 28.4% to 90.8% in financial 2020 quarter 4. So we realized that helping others understand TB prevention through capacity building, routine file audits, and caregivers meeting can improve TPT uptake among children and adolescents living with HIV amidst COVID-19 challenges. And with a picture here, mentoring the data person on how to document and update the INH register. We learned that routine on-site coaching, client file audits, continuous health education to caregivers, and community delivery of INH alongside art, while ensuring timely documentation, we can improve TPT uptake among children and adolescents 0 to 19 years living with HIV. We came to a conclusion that using data and the dissemination of TPT information is very key in improving TPT initiation among children and adolescents, because if we had not used the data to identify the gap, we wouldn't really have seen where the gap was, and we wouldn't also have seen how far we had gone with our targets. Then if we are not disseminating the TPT information and mentoring the health workers and the caregivers on TPT initiation among the children and adolescents, I believe we wouldn't really have made it or succeeded to achieve our targets. So we therefore recommend that there should be continuous engagement of caregivers and facility teams for optimal management of children and adolescents living with HIV. Since in INH initiation among children and adolescents is one of the optimal management in the HIV treatment and care. URCs, we are partnering with TASO, Community for Development Foundation, Uganda, and Youth Alive to implement services and strengthening health system delivery and services in the region. Yeah, thank you so much for listening to me. God bless you.
Hello, my name is Kawia Patrick. I am a monitoring and evaluation officer working with Nama Wellness Community Center in Lukojo Kayunga Road, Mukono District. I'm here to present to you my QI abstract, which is titled The Role of Village Health Teams in Management of Health Emergency Crises. Around March, when COVID-19 was identified in Uganda, the first cases identified in mid-March, the government put in place stringent measures to make sure that the virus does not spread quickly to many parts of the country, and this affected access to services, especially health services. People could hardly move to health facilities, and the same was happening to the health workers. They found it very hard to access healthy facilities. So as such, Nama Wellness Community Center, as a community-based health facility, thought it important to use the village health teams, the structures at community level, to pass on information regarding the spread of COVID-19, how to prevent it, how to make alerts, and how to manage cases. Through that, 50 VHTs were trained in COVID-19 handling. They were given all the necessary information and the guiding documents, both from the World Health Organization and the Ministry of Health. At the same point, they were given temperature guns and pulse oximeters. to use in the screening of COVID-19 cases at community. Between May and August 2020, 659 referrals for danger signs among children and women were made to health facilities by the VHT supported by NAWE. By then, hand washing was at 35%, but within 4 months, this moved to 70%, which is a 35% increase. Within that same time, the VHTs identified 60 malnourished children. These were enrolled on the nutrition program that is run by NAWE, and by end of August, 54 children had recovered and were well nourished. Additionally, the VHTs participated in the distribution of face masks. These were given by the government of Uganda, so the VHTs took part in this exercise and they distributed over 10,000 masks. Through the VHTs, around 1,300 people have been screened for COVID-19 using the temperature guns and the pulse oximeters that were given to them by NAWE. And within this same period, 50 alerts have been made to the COVID-19 response team in Mukono district. Lucky enough, none of these cases has turned positive. The lessons learned from this one, the village health structures, if well facilitated, can potentially address the challenge of health staff shortages at health facilities. The second point is village health teams are a cheaper option for providing health services at village levels, given the fact that Uganda still has a gap in terms of the health worker and patient ratios. The conclusion is village health teams have the potential to transform the health system, especially in the low communities. This can only be done if they are well supervised, motivated, and provided the needed supplies to do their work. My recommendations are 3. First, the VHT program needs to be made operational and well facilitated if we are to benefit from its enormous strength. Secondly, refresher trainings for VHTs are needed to build their knowledge and skills. And thirdly, more funds need to be dedicated to the community health teams. This can be from both internal and external partners. For listening to me, God bless you.
Hello, my name is Rebecca Mirembe Mulindwa. I work with USAID Rights E as a nutrition and WASH advisor. I'm presenting a poster on COVID-19 pandemic, providing opportunities to improve nutrition outcomes. How Rights E has used the family care group model to promote healthy feeding among vulnerable populations. Introduction. In order to improve the quality of maternal, infant, and young child nutrition counseling and support in a region that has been hampered by the COVID-19 pandemic, Rights E has had to do business differently by using the family care group model, which is implemented in 17 districts across 33 sub-counties to promote appropriate maternal, infant, young child, and adolescent nutrition at community level. Methods. Rights E worked with the community stakeholders and health facilitators, conducted small group dialogue meetings and home visits, carried out routine nutrition assessment using mark tapes, and adopted the family care group model to reach people at household level. Results. A total of 1,476 pregnant mothers, 4,895 breastfeeding mothers, and 1,221 caretakers of children 0 to 23 months were reached through the family care groups. Through the groups, a total of 6,400 children 0 to 23 months were reached in the third quarter, that is April to June 2020. The care groups are supported by 635 leader mothers, those are the care group volunteers, and 248 VHTs who are monitored or supported by health assistants, community development officers, and nutrition focal persons at a nearby health facility. To promote an ideal home, a total of 2,115 care group members established vegetable gardens, and a total of 1,215 have chicken to provide eggs for their children to improve dietary diversity. Discussions. Care groups are used to promote key family care practices, including appropriate feeding during pregnancy, maternal feeding during breastfeeding, exclusive breastfeeding, complementary feeding, micronutrient supplementation, vegetable gardening, antenatal and postnatal care attendance, birth preparedness, health facility delivery, immunization, and availability and use of latrines, drying racks, rubbish bins, bathing shelters, and other water, sanitation, and hygiene facilities. Key practices like soap making, making of energy-saving fireplaces, construction of latrines with tight-fitting covers. Group savings were rolled out and adapted by the groups. Lessons learned. There was a reduction in malnutrition in the communities implementing care groups. Access to and utilization of health services like health facility delivery, antenatal care attendance, and use of modern family planning methods increased due to continued peer support. We also learned that building district capacity to self-sustain is a process that should not stop within the raised activity period. There is need for continued engagement with and empowering the district teams so that they become resilient to handle health challenges, especially now in the COVID-19 context. Conclusion. The family care group model is a best practice to promote community safety, adoption of key behaviors to prevent malnutrition, prevent illness, while also promoting access to and utilization of health services. Thank you.
Ladies and gentlemen, protocol observed. I'm Dr. Rosemary Auma, a medical officer at Kitgum General Hospital. I'm here to take you through the use of QI methodology to improve TB treatment success rates in Kitgum District. Below are my co-authors. Our implementing partner is USAID, Rights North Acholi. The population of Kitgum District is estimated at 214,732 people. We are therefore expected to notify 558 TB cases in a year. Kitgum District has 13 diagnostic and treatment units, 3 gene expert sites, and 1 public X-ray machine. The TB treatment success rates for Kitgum District as of October-December 2018 was at 51%. That was way below the national target of 85%. This was contributed to by only 3 sub-counties, as highlighted green on the map. A majority of the sub-counties had very poor and low treatment success rates, as shown on the map. This low treatment success rate was attributed to no TB work improvement teams at the different DTUs, knowledge gaps of the staff on TB treatment success rate, poor documentation processes, and no mechanisms of patient follow-up were in place. Looking at the methodologies that we came up with, one was formation of TB QI teams that involved conduction of CMEs to introduce QI concepts for TB. In these meetings, we selected the work improvement teams for TB. We appointed TB focal persons at the different DTUs to help track TB processes. Through monthly support supervision, bi-weekly phone calls to the facility TB focal persons, we were able to empower the TB work improvement teams on processes of documentation, where the teams opened up active documentation journals that were updated on a monthly basis. They picked up and used appointment registers, which helped to track patients that had missed appointment and were brought back to care, ensuring that they complete their treatment. And as the DTLS, I updated the district TB register, and this helped to fast-track patients that were transferred out to different facilities, being brought back to care and their outcomes updated, and it also improved in the district TB patient management. We also followed up our patients through line listing of the TB cases at the different DTUs. We worked with the VHTs who are part of the work improvement teams at the facilities, and they supported us in following up these patients and bringing them back to the facilities, and also they helped in monitoring the community dots. The TB focal persons helped to give phone call reminders to the patients that had active numbers, leveraging on the airtime provided to us by support of Rights North actually. There was site liaison with other facilities to track patients that were transferred out to other facilities and their outcomes updated in real time. This map shows us the TB treatment success rates per sub-county before and after the intervention. Clearly, we can see that there was a great improvement where 5 sub-counties had a treatment success rate of above 85% compared to the 3 sub-counties that scored above 8% in the quarter of October-December 2018. Looking at the trends of TB treatment success rates, we see a marked improvement from 51% to 84%. That is just 1% below the national target of 85%. And with this, a number of interventions were put in place, as I earlier mentioned. But as a team at the district, we significantly saw that the support from the VHTs on following up processes and monitoring community dots was key in improving this treatment success rate to 84%. In our discussions and lessons learned, we see that quality improvement brings a unique concept of sustainability, and frequent review of data empowers facilities to develop solutions that they can easily and quickly implement. And we see that through monthly review meetings by the work improvement teams of TB, they're able to get an opportunity to review and plan for any new changes. Documentation processes are improved through teamwork, and client-centered care through follow-up processes is key in improving treatment success rate. As we conclude, we see that quality improvement processes are a sustainable way of improving TB treatment success rates. I acknowledge USAID, Rights North actually, Ministry of Health, Kitgum District Local Government, and the DTUs at Kitgum District. Thank you.
All right. Welcome back from that session. I should say that those were really impressive and informative presentations, and I want to use this opportunity to thank our presenters. So, as the country strives to improve the quality of care, it is very important that we get these innovations in place. And for that matter, I want to thank the presenters for the efforts they invested in implementation and preparation of these presentations. We are going to go direct to the chats and see if there are any questions. Maybe we can go to question and answer. I can see someone here, Akena, saying that the above question is for Chiano, but I don't see the question. I don't see the question here. Then the other one is a comment from one attendee, and is directed to Rosemary, and she says, thanks for the impressive work. What specific challenges did the team encounter with the sub-counties that did not improve? That is a question to Rosemary. I think that was our last presenter, Dr. Auma Rosemary. I don't know if she's online. She could respond to that question. Do we have Rosemary online? Okay, so we don't have Rosemary, but we can always direct that question to her, and then she can answer it, and as we publish this work, maybe that answer will be good from that publication. But we thank you, our anonymous attendee, for that question. Again, ladies and gentlemen, these have been such very impressive presentations. These are very good innovations, and as we strive to achieve the client-centered care, we need to have a combination of both technical skills and such innovative strategies. I want to thank you all for those presentations. I don't know if there is any other question to our technical. Okay, I can see in the chat we have someone called Ronald. Martin is saying, Ronald, writes EC. Which of the shared changes did you attribute the improvement with the greatest contribution? That is number one question, targeting Ronald. Then the other question is, who funds the community distribution and caregivers meetings? Still to Ronald. And then the other is it visible, given that many clients have no phone contacts and share wrong addresses for follow-up? Are there side effects to IPT that affect its uptake or myths and misconceptions by the community? So those are questions directing to our presenter, Ronald. Do we have Ronald online? Our IT support, you could allow Ronald to respond to those questions. So we have Ronald physically present. You're most welcome, Ronald.
Thank you so much. The first question, which changes attributed to the greatest output? I would attribute to first documentation. It entails a lot. It entails documenting in the files, documenting in the INH register. So when we address documentation, then community delivery of INH to the community, they really attributed a great change. Then who is funding the community volunteers? Namutumba Health Center 3 is being supported by Rights EC. So they have an SDA that is budgeted for them to do the community outreaches and the delivery of the INH to the community. Then about wrong phones and no contacts, yeah, this is really there. Some people give us wrong contacts. However, we use, we have the tracking tools that are in the client charts that we use for directions to the caregivers, and also our community linkage facilitators, the volunteers, are specifically in particular sub-counties, so they know most of these clients physically. So a combination of our community linkage facilitators who know these clients physically and family tracking tools really directed us to their places, so we're able to deliver the INH. Then another thing, whether we have side effects and misconceptions, yes, we have. How did this affect? Since we are dealing with the children and adolescents, these are very sensitive ages, and some of the caregivers had also been initiated on INH, so some of them developed some side effects, and one of the things they didn't want their children or those that they were caring for to go through the same effects. So they had halted and deliberately refused to give the INH to their children in the fear of their children also having the same side effects. But through orientation, teaching them, letting them that what affected them may not affect their children, so they agreed to it, and yeah, it really gave us a good thing. Then other people had misconceptions. One of them said INH increases his libido, so he fears to give them to their children. And so we also had to clear that misconception. So this really could have affected the initiation, but at least when we cleared all these misconceptions, yeah, we saw the results, and they're really promising. Thank you so much.
All right. Maybe before you leave, Ronald,
Yep.
I think you have another question here. So someone says to the TPT presenter, after how long is someone due stroke eligible to gain a restart TPT or IPT once finished the whole course of treatment?
For one to finish the whole course?
Yes.
It's 6 months. Someone has to complete 6 months of INH.
So the question is, after 6 months of completion, when can someone restart that treatment? Because the question is, after how long is someone due stroke eligible again to restart IPT once finished the whole course of treatment?
We've not yet researched about that. However, what's recommended for now is that everyone has to get initiated on INH and has to complete the first 6 months. Yeah, okay. Maybe we shall continue research about that, whether we should really start initiating someone after the first initiation, after completing the first initiation. Yeah.
All right, thank you so much, Mwesugwa Ronald, for those responses. I'm trying to see if I have any other questions here. So Rose here is saying, this is an answer from Rose. There was a question targeting Rose, which was asking about challenges. What specific challenges did the team encounter with the sub-counties that do not improve? So Rose here has responded and saying that thanks for the opportunity. In sub-counties of Orom and Namokora, the community are mobile the communities are mobile in search for pasture for their animals, so this affects follow-up, hence TSR compromised. So that is her response to the other question that was targeting her. I can see someone here called Jolie Violet and is saying to the TPT presenter, after how long? No, this one has been asked. So let us check again in the chat. I don't see any other questions here. I don't know if there are any questions in the audience. Our physical attendees, do we have any questions? Please send in questions if you still have the questions. We are still within time. So there's this other question, and it is from one of our online participants targeting Fosciano. So here it is saying that thanks for sharing the innovation. What additional interventions were implemented to ensure completion of diagnostic cascade? Do we have Fosciano online? Fosciano? Oh yes, we have Fosciano online, so he's going to answer this question.
Yes, I'm available, and I had already answered this question on chat.
What was that? I didn't hear that.
I said I've already answered these questions on chat, all.
Please, if you don't mind, you can do it so that, because I can't seem to get that answer.
Okay.
Kindly help us. Yeah.
Yes, when we brought this idea, first of all, went through the administration of each unit listed above the two facilities, and we discussed the importance of this ICF stamp in a way that we told them the advantages of this ICF stamp, which we have said that it first of all helps us in early diagnosis, and of course also putting the patient on treatment immediately. That helps us to limit to break down the TB transmission. Now, plus other advantages that I've already put on chart, but that's one thing we did. We made sure the administration of these facilities were in the know of this activity, and then secondly, we took staff through CMEs on case finding using this ICF stamp. That was the second aspect of it. And then apart from that, we also did a lot of supervisions, both manual supervision and mentorship with our DTLS, the IP technical officers. And then we also encourage them to use data. We remind them how they are performing in the two facilities. That was very crucial for them to own the strategy. Basically, that was done, but there were other things that were making this ICF stamp to go on improving the case finding. One of them is donation of the microscope to this facility. There were issues like integration of services, TB services, into either community outreaches, the use of the VHTs in screening people and bringing cases to the facility. The other thing was leadership and governance. It was very crucial, as I put it earlier on. But basically, these were enhancing factors or strategies. Of course, also the hub system was available. Although they do microscope, they also could do gene expert. So all in all, the facilities above were able actually to surpass their targets, their TB targets. Basically, those were the few strategies we applied.
Yes, thank you so much, Mr. Fauchano. I think that is an elaborate response. Thank you so much. We have another question. It is targeting Dr. Rosemary. And this participant is saying, thank you for the good presentation. How did you handle the issues of wrong names, stroke telephone numbers given by patients, which I know is common, I think, in our area. So how did you handle the issues of wrong numbers and telephone numbers from patients? Then the delay of results from the hub. And this question goes to Rosemary. I think she was online. I don't know if she can respond to this. She gave us a response earlier on. So I don't see any other question in the question and answer section.
Hello, Chair.
Yes, please.
Hello, Chair.
Please.
Yes, good afternoon.
Good afternoon. Please go
Rosemary
ahead.
missed the question. Can you repeat the question for Rosemary?
All right.
Yes, can you repeat the question for Rosemary?
So the question is about how did she or how did the team handle the issues of wrong numbers and names given by the patients while you're implementing your interventions. And then the other part is how did you handle the issue of delays from the hub? So that is the question, targeting Rosemary, Dr. Rosemary.
Yes, thank you so much. For the issue of wrong numbers, for the issue of wrong numbers or numbers that are off, I had earlier mentioned that we line list and then do geographical mappings of where these patients are. That is where we leverage on the VHTs and the facility focal persons to support us reach these patients physically. And then we only do phone calling to those with active phone numbers. Then for the issue of delay from the hub riders, as Kitgum District, we do real-time relaying of results, where if we get a positive client, we quickly call back the facility that has sent in the sample so that the patient is started on treatment in quick time as we wait for the hub riders to relay back the printed copies to the facilities. Thank you.
All right, thank you so much for that response. So for those who did not have correct numbers, they were visited by VHTs. I think that is a very good response. So we have two hands up here. We have Lois Lamiru. I think our technician can allow her to ask her question or give a comment. Thereafter, we shall have Robert Andiku. So I want to have Lois Lamiru to give us her question. Lois, you've been allowed to ask your question, please. You can unmute yourself and give us your comment or question. Okay. We can't. Are we having Lois on?
Hello? Hello?
Yes, please, go ahead.
Hello,
Your question.
Hello?
Please go ahead. Ask your question, please. We can hear you.
Okay. Good afternoon.
Good afternoon to you.
My name is Lois. I have pending response which was posted yesterday, And I felt it is the right time for me to respond to the question which was posed yesterday about photograph use in reducing birth asphyxia. It was a technical problem.
So, Miss...
That's why...
Okay, Miss Lamaru, please. I think since we are in another...
Yes.
We are handling a different sub-theme right now. If you have your response, you can write it in the chat. We shall capture it in our publication. Please write the question that you're trying to answer and the answer to that question. Thank you so much. Can we have Robert Andiku?
Thank you. I'm on. Can you hear me? Hello? Can you hear me?
Yes, please. Yes, please, Robert, we can hear you.
Oh, yes, please. Good afternoon.
Good afternoon,
I
Robert.
have a question to the presenter who presented about, unfortunately, I don't take the name. He talked about cure rate and success rate, which showed much improvement. We wanted for him to clarify and share with us the experience, how the VHT, the linkage facilitators, were able to approach challenges in regards to loss to follow-up, adherence to treatment that brought up these good results.
Robert, I don't know if I got your question. Please make it so precise so that we can get you so well. Sorry.
Okay, we wanted to know how they use the VHT and the linkage facilitators. You get me there?
Yes, how they use the VHTs
and the linkage facilitators to enhance adherence to treatment and follow-up of the loss to follow, which are led to high treatment success and high cure rates.
So whom are you targeting with this question? Who was the presenter?
Unfortunately, I did not pick, but it presented about increase in success rate and cure rates before Fontanio.
All right. Maybe you're referring to improving treatment success rate and cure rate, which was presented by Kavale Geoffrey.
Yeah, sure.
That one.
Okay. So I don't know if Kavale is online right now and can respond to that question. I think Kavale is online.
Chairperson.
Kavale is online.
Chairperson, I'm online.
Yes, please, go ahead.
Thank you for the question. The VHTs and linkages facilitators, many of us could be aware that with the HIV arm, there are linkages facilitators that are attached to the HIV clinics. And then already in the community structures, there are also village health teams. Some of the village health team members in our region are still active. And through the sub-county health workers or health assistants, these village health teams are attached to the facilities to support in some of the community interventions. So what we did, through the meetings that I talked about, the engagement of the health facilities, we agreed with the in-charges to at least attach a community linkages facilitator to the TB clinic. Now, the community linkages facilitators are facilitated with a monthly stipend. So in that way, there's some bit of motivation for them to keep coming to the clinic. So they are encouraged to come around and also support the TB clinic. And for the village health teams, in the community activities that they are engaged in, they are facilitated with some kind of lunch refund and transport refund to support in many of the activities. So with the works that they do with the TB focal persons, they are enabled. Okay, maybe the other thing that I mentioned about was the use of the appointment registers at the TB clinics. So the people who are in the communities, as in the VHTs or the CLFs who are attached to the clinics, are able to monitor the people who have missed their appointments. And in such a way, they are line listed and they move to the community to ensure that they bring them back into care or even deliver medicines to them in the community. And those that have missed appointment, like I mentioned earlier, are brought back. And they also support in the sputum monitoring, where they still move along with the sputum containers to pick the samples. I don't know if that answers the question, but that is how we engage the community linkages facilitators and the village health teams. Thank you very much.
All right, thank you so much, Mr. Geoffrey Kabale. I hope, Robert, you've been answered. So far we don't have any other questions. I want us to close this session, but before we do that, okay, we have one hand in the audience. Please go ahead and ask your question. We have less than 3 minutes.
So much. My concern goes to Mr. Mwesigwa Ronald. My concern is, how have you been monitoring and managing adherence of isoniazid uptake, especially in these adolescents? Because we know this age group is very strict. Sometimes you can give them and they just keep them at home and they don't swallow. So how have you been monitoring them? Thank you.
Okay, we can have Ronald to answer that question.
Yeah, thank you so much. Actually, what you're saying is true, because one time we visited a client and we found teens, including INH plus ART, all had been kept there. However, like we know, empowering the caregiver is really one of the basic things that we can ever do, because we're not there to follow them up in their homes, but obviously one of the reasons why we called for the caregivers meeting was to let them know the importance of INH to their children. And we cleared the myths that they had about it, then encouraged them and requested them to make sure their children take the medication. So it was just empowering the caregivers, talking to them. Then they gave us surety of giving their children what? INH. Then for the community visits, obviously we had those abrupt visiting to the communities. We would check out, ask the parents to show us the medication, just as it's done the adherence test, the adherence in the ART clinic. So we would ask the caregivers to show us what is remaining, what has been given, what is remaining, and what needs to be added. So briefly, that's how we try to monitor adherence, though still I insist that the basic thing is addressing this issue to the caregivers, because they are directly monitoring the INH being taken by their children. So they could choose either not to give them, because they also have their own issues why they're not giving it to their children. Thank you so much. I don't know whether that really answers something.
Yes, thank you so much, Mr. Mwesigwa Ronald, for that response. Ladies and gentlemen, we are coming to the end of this session. I want to, at this point, to applaud our presenters, and I want to specifically read out their names. I know by the end of these recordings, we must have forgotten them, but they did a great job. So we had Mr. Kabale Geoffrey. I can't see where he works, but we had him as a presenter. We had Aluko Doreen, works with Tasso. We had Karobe Fauchino. We had Mwesigwa Ronald from Namutumba district. We had Kawoya Patrick he did his work from Nama. And then we had Rebecca Mirembe, works with Rights E. So those who are and Dr. Auma Rosemary. So those who are our presenters tonight. They were very impressive presentations and very innovative. And I can't emphasize enough how important it is to come up with innovations that are patient and community involving. So, and most of these people showed us how they involved the communities and the patients in provision of care. So thank you so much, ladies and gentlemen. Those who attended physically, we appreciate your attendance. Those online, we appreciate your resilience, and we wish you a good day. I'm going to invite the MC to give an official enclosure. Thank you so much.
Let's join our hands to give Josephine a round of applause. Thank you so much for moderating this session. And in addition, we want to thank all those who have presented their posters, and of course, they managed to put in time to respond to the different comments and questions that have been brought forward. So thank you so much for sharing your experiences on quality improvement in the healthcare setting. We have come to the end of day 2, and live from here, Misteo Hotel and Residences, we want to thank you all our online delegates who have listened in, and we want to appreciate even the panelists who have not been able to be around, but they have been online, following closely, and also responding to the comments. And to you, the delegates who are out there, in case you have some pending questions that were made and they were not answered, please just leave them in the chat. Every question, comment will be attended to, and you will get the response in due course. Tomorrow is more of a half day because it will be the last day, and what we expect in the morning, just to give you a snapshot on what will happen on day 3, which is the last day. We shall have a start off at 9 a.m. here for the plenary session in Bunyonyi Hall. And we shall have a presentation from our own Dr. Martin Sendiona, who will be talking about the progress made on the health facility quality of care assessment program. And of course, we give a way forward. And we shall also have a keynote address by Professor Rhoda Wanyenze of Mackay's School of Public Health. And of course, the session chair for that morning presentation will be none other than Dr. Agre Batesachi, who will be here with us. So after break, we shall have the normal breakaway sessions, and the themes for tomorrow are basically governance and special groups, which will be in Bunyonyi Hall, where I'm speaking from. In Aswa Hall, we shall be having a theme, improved service delivery models, medicines and health supplies. And then in Kafu Hall, we shall have service delivery and infrastructure. I'm calling upon all the presenters who are supposed to present tomorrow. Please be around. We will really appreciate your presence tomorrow to be here in person to present. However, apologies will not be wanted, but of course, at times they are inevitable. But make sure that at least you have a replacement and you inform the organizers accordingly. So I want to thank you so much for being a good team. And at this juncture, allow me invite the co-chair of the conference, Dr. Alex Mwisho, just to say a sentence or two before we officially close the day's business. So I'll request Julius to allow Alex to come forward, and just he can use any microphone near him to appreciate the online delegates who are more than we who are here in this hall. Over to you, Alex. Okay, so, let's, since we have come to the end of the day business, can we all stand up who are here, even you who are online? And I'll request a volunteer to give us a closing prayer. Okay, Dr. Alex, you are good at praying. Just pray for us and we go. And we call it a day. Oh, Julius. Hey, who is, oh, Dr. Tai? Oh, fine. And usually God listens very much to prayers from ladies. So all of you. So online delegates, we're having a closing prayer. So you'd also humble yourself wherever you are. Over to you, Dr. Tai.
Humble ourselves and pray. Our Heavenly Father, we thank you for such a successful day 2 of this 7th annual conference. Father, we thank you for the journey masses that you gave us this morning, and we commit the journey masses that you're going to give us this evening, trusting that you'll keep us sound and safe. Lord, for all the deliberations that we've had, we would like to say thank you. Thank you for the brains that have been working behind the scenes and have been able to share with us this rich knowledge, a rich body of knowledge that we pray will go on to impact on the citizens of this country. We pray, Lord, that you continue to nourish and feed us through the rest of the day and bring us refreshed for yet another day 3 of this QI conference. Bless our evening, bless our going, and bless our coming back tomorrow. In Jesus' name we pray.
Amen. Thank you so much. God bless you. Bon voyage. And those of you who are here in this hall, we have evening tea. So you can make sure you have the evening tea. And then as organizing committee, of course, we shall have a 10 minutes wrap up to organize very well for tomorrow at the usual place where we were yesterday. Thank you so much. God bless you. Ciao, ciao. Bon voyage. See you tomorrow.